Right.
Okay.
Good to go.
Okay. Okay. All right. Go ahead. You.
So I'm Angela Garcia. I'm one of the board members for the Florida Aqua Coalition, and I'm going to introduce our next speaker. This is Dr. Eghrari-Sabet. So thank you for giving us a great way to know how to pronounce her name.
Yes.
She's one of our speakers here. She's a dynamic speaker. She's been sought after all over the country. So it's great that we have her here. She's going to be doing a very interactive presentation. So everybody's participation would be greatly appreciated. She's got an appointment at George Washington School of Medicine and as a clinical assistant professor. She's involved in their curriculum development as well as doing a lot of education with physicians on digital health and telemedicine. So it's great that she's able to present with us and also have our hybrid online group. She's a huge advocate when it comes to patient care and improving the quality of life. And so her research and experience in clinical trials gives her an extensive opportunity to talk with us and engage with us about this shared decision making. So thank you for being here.
Sure. Thank you. Pleasure to be here. All righty. So, and it's a pleasure to be here. It was a bit crazy getting here. I am from Washington, D.C., so I fly in today. And of course, the plane got delayed. So then I needed to go to another airport and get here. But you have lovely hot weather here. This is what I would expect. So let me give you a bit of my own background, which is I am an allergist. And many of you know, in order to grow up to be an allergist, you're either first internal medicine or pediatric trained. We're the only board specialty that is under two boards, under pediatrics and internal medicine. And I did my primary training in pediatrics at the National Children's Hospital. And then I grew up to be an allergist. And I did it at a program that no longer exists, but it gave me an interesting background of patients. So it was between Children's and Walter Reed Army Medical Center. This was during the first Gulf War. So I did like a lot of anthrax stuff. And then the NIH, right when it was really the height of HIV, and Anthony Fauci was my attendant. So it was an interesting time to do all that. A lot of people will ask me, why did I become an allergist? And I think, especially apropos of the presentation that we just had about the patient journey, I want to share that with you. So I went to NYU for medical school, New York University, which some of you may know is now free, completely free to go to medical school. And that's in order to be able to encourage people to go into certain specialties that are not as lucrative and not to burden physicians with their tuition payments. But when I went, it wasn't free. I graduated in 1989. So it definitely, my poor parents had to pay. So back in those days at NYU, you would graduate and have your big ceremony in Washington Square Park. Now they actually do it, I think at Yankee Stadium, but you did it at Washington Square Park. And then you would go to eventually to Carnegie Hall, where I have been on the stage at Carnegie Hall because it's where I got my medical degree. And so between Washington Square Park and Carnegie Hall was time for lunch. So my mother made the reservation at Tavern on the Green, which is a beautiful restaurant that's right in Central Park. But the day that we went to get to go to lunch, there was a strike. And the strike was for all the people that were working in the kitchen. So we literally had to like cross the picket line in order to get in. And they're yelling, I had my cap and gown over my arm, and they're yelling, if you're so smart, why are you crossing this line? And I'm like, listen, you know, my family's going to be hypoglycemic. I need to feed them, right? So anyway, we get there and we sit down, and it's lovely. And, you know, it's a proud day. My father is a doctor. Another little note, I'm half Iranian, half Irish. So my father is a surgeon, and I call him the Persian surgeon. So my father is a doctor. My mother's so proud. My husband is there. My brother and sister were all there. And they just take our orders. And for just drinks. And my mother orders an iced tea, and she takes her lemon and she squeezes it in her iced tea and she drinks it, and she pushes back from the table about 2 minutes later, and she looks at me and she says, "Oh, Jackie." And I think, oh no, because I have technically already graduated. I have moved my tassel from one side to the other at Washington Square Park, but I haven't yet said the Hippocratic Oath. That's what's going to happen at Carnegie Hall. And my mother is very, very allergic to sulfites. And what they had done was sprinkled everything, including the lemons, which, you know, don't turn brown, right? They sprinkled everything with sulfites in the kitchen as a preservative because they knew that the service was going to be so slow. And so she takes a sip of her iced tea and has an immediate anaphylactic reaction. And she basically, I get her to the restroom, and fortunately my dad, the Persian surgeon, comes with me, and she has a full-blown anaphylactic reaction with laryngeal edema. She's unconscious, she's vomiting. I mean, it was bad. And we eventually bring her back. She did not have an EpiPen because she didn't know that, well, sulfites can get you at any point at any time. And I was not yet even, I was technically an MD by about 45 minutes, but I wasn't actually a practicing physician. So that's how I become an allergist. I was already signed up to do pediatric residency, and I knew that I was going to go into a subspecialty, and that's what I eventually ended up going to. But that's all to tell you that this idea of really understanding the patient's journey, the family of the patient is so important. And in my mother's case, of course, she was not a pediatric patient. And so the family of the adult patient is also so important. So that's how I get to you today. So we're going to start with this first slide. Let's see. Why am I not going to my next enter? Nope. We went back the wrong way. Okay. A little technical difficulty. Okay. We'll get that fixed here, because what I want to share with you is a slide that's going to come up here in a second that is a beautiful quote. And now, how did you do it?
Oh,
That one.
oh, you just pressed.
Okay. Yeah, okay, got it. Okay. So the beautiful quote says, 37% of physicians believe that patients want the doctor to make the decision regarding their medical treatment, meaning I am the doctor. And of course, you people want me to make your decision. However, only 7% of patients say that that's what they want. Right? That right in there that's the nugget. That's the whole enchilada for what is shared decision making, is that, think about that, 37% of physicians feel that they should be making that decision without any input from the patient, whether they feel the patient isn't capable, or they feel that that's their job, or they feel that that's what the patient expects of them. There's a whole lot of reasons why, but that is what they expect. So let's do a little bit of an overview of what we're going to talk about today. And we'll start with the defining the present gaps in asthma care, and to be able to talk about first communication skills. So here's how I like to be able to put this is, it's not that we need better drugs, as we've heard all day today. There are some really incredible drugs. And again, just to give you a little bit of perspective on this, is when I graduated from NYU in 1989, you know that so many of these biologic drugs are an some sort of a cytokine, right? Particularly an interleukin. And you've probably heard about ones that are anti-interleukin 5 and 4 and 13. Well, when I graduated medical school in 1989, there was interleukin nothing. It didn't exist, right? There was not interleukin 1. It did not exist. The actual molecule was understood, but it wasn't called interleukin 1, because to call it 1, you have to know there's going to be 2, 3, 4, and 5, right? And that wasn't understood at all. So it's not that we need better drugs. We certainly don't need smarter physicians. I mean, if you see the stuff, the people who are being trained now as doctors, my younger son is one of them. They are brilliant, They are brilliant. It's not that we need smarter doctors. And as we've seen from presentations today, it's not that we need more motivated patients. So then what is it that we really need? Well, the thing we really need is communication skills. That is the thing that we need. That is the therapy that we need. That is the ability to lead from diagnosis to wellness that we need, is the communication skills. And then how do we make that treatment plan? So we're going to actually role play this today. What I want you to think about here for a minute is using shared decision making and how that actually really plays out in terms of adherence. So a brief little adherence thing. If we were all business people and marketing people, you know, there's that whole idea that 80% of your business comes from 20% of your customers, right? So if I could only have 20% of my patients be adherent, they would take up 80% of my time because they would be in such close contact with me that I would be able to keep those people well. And as a physician, a practicing physician, you're always looking to be able to help more people, find more patients. There is nothing better than a testimonial of, she helped me, she fixed me. Now, the tools that I wield are therapies, are medications. I write a lot of scripts, right? I do a lot of counseling. I am not like my father, the Persian surgeon, where there's a certain skill that I may have that somebody else may not have with a scalpel. I use all the same drugs that anybody else can use. I use all the same adjunctive therapies that anybody else can use. So what makes me a more efficient physician who's really able to help patients? It's not the drugs that I have access to, because anybody has them. It must be the way that I transmit this therapy to patients. That must be the magic, right? So that's why this little bullet point of quality of life, of adherence is so important. And then what that translates into for a patient is quality of life. They're like, as we heard just in the presentation before, my whole life changed. The whole quality of my life changed once I understood my asthma and what I'm supposed to do about it and what is out there for me as a treatment. And what does that lead to? It's healthcare literacy. And of course, that's one of our bullet points here. And in the end, for people that run systems that look at efficiency, what they're looking for in efficiency is that you cost less. And the biggest cost is you have an asthma attack. You have an asthma attack and you ring up the bill. You have an asthma attack and there are collateral costs to that, right? Which is a child has an asthma attack and the parent's not at work. The number one reason why children miss school is because of asthma. And for every child that misses school, where is that parent? It's not like they're at work. Now, things have drastically changed because of the pandemic, because you can then now work from home. But how well are you working from home when you have a sick kid? You know, there are plenty of times people choose to work from home because their dog is about to have puppies. But imagine if this is your child who's having an asthma attack. I mean, I really don't think that you're there, you're present at work. So think about those things. Okay. The learning objectives. We're going to identify the patient preferences for their asthma treatment and how do we elicit that, and we're going to role play that. We're going to teach those effective communication skills, and we're going to come up with that ourselves. Is what is a effective communication skills? I think we just saw one of them, which is storytelling, an incredibly effective communication skill. And then what is the patient's ability to adhere to a treatment plan? Okie doke. All right, so let's get to the business of doing that, of making that real world scenario. So the lack of patient preferences in their asthma treatment plan that is provided by their healthcare provider. So have you seen that? Have you heard of that? Can you give me a scenario? Have you yourself been through something along those lines that you go in for whatever the cause is to see a physician, and you really don't have any sort of input into what your preference is. That's not even part of it. Go ahead.
So when I moved from the east coast of South Florida over to the Tampa area, I had to get all new providers. Like, they were nice enough to be like, here's a couple of extra prescriptions. So in the transition of getting a doctor, so I thought, okay, I'm at the university. So it's the University of South Florida, but haha, it's actually Central Florida, West Coast.
Okay.
And I just think they couldn't come up with catchy names.
Right.
At USF, I go to one of the physicians at the university. So I'm like, I don't even have to I get to just go. I don't have to take off work. I don't even have to put in for PTO. So I go over, I see the physician, and I'm like, here's my history, here's all my meds, I'm filling out all the forms. And then we have this conversation, and I'm like, oh, okay, this is gonna work. And then as I leave, I look at my prescriptions, and I'm like, none of these are the meds that I had, changed everything.
Everything.
And I was like, wait a second.
Right.
I've been on all of these and they don't work, which is why I'm on this.
Right.
And so then having to go back and forth with, as a healthcare professional, with another healthcare professional.
Right.
And I'm like, we didn't even talk about these. I was letting you know, this is working for me well. Here's where I think I need a little bit more support.
Yes.
Maybe we can add this on. It was just a blinded interaction. It was the first time that I experienced that as a healthcare professional, because when I don't put down that I'm a pharmacist,
Yes.
then people will treat me like a patient.
Yes.
Otherwise.
And
they
think
walk
of that
in
statement. People will treat me like a patient.
Yeah. Otherwise, they want to have a conversation with me.
Right.
Because I'm a colleague.
Yes.
So
Right.
that was literally one of the first times in 20 years that I was
Right.
treated as a patient, and it was horrible.
Right. Right. People will treat me as a patient. So let's remember that, because we're going to need that when it comes to how do we teach healthcare providers, which is, have you ever been treated like a patient? Because as you say, it's horrible, right? So that's an excellent example of the real world case scenario of you go in, you see the doctor, and suddenly everything gets changed and none of that was discussed with you. And how could that be? So here we go, addressing the gaps. So the bullet point is that you need to involve patients with their treatment decisions to improve adherence to asthma therapy. But my question is, instead of putting this lovely bullet point up there, I want you to say, why would a patient want that? And how did they think it would help?
So they control because they can't control anything.
Say that again a little louder, so the folks at home can hear you.
So they can have some control over the disease process, because in the chronic disease processes, they can't.
Ah, that's a great one. In chronic disease processes, you can't control anything, and they're looking for control. Right, right. Anything else? Why would a patient want this?
I think patients are sometimes afraid, because when I've interacted with some patients about, so tell me a little, some of the things, and they're like, oh, well, whatever you say.
Right.
And they're very quick to relinquish any input, but it's because they know they really don't have any. And so when you ask them, a lot of times they haven't ever been asked that before. So they don't know what to do, and they don't know what to say. So they're like, I trust that you make a decision.
Right.
And sometimes you have to coax it out of them. But it's so much more effective because you learn the little nuances, like they were saying, can you afford this? What does your lifestyle and your schedule look like? Can you do all of these other things? And I was with Dr. Perpich in his clinic. And so it is sometimes you make a decision because the patient shared something with you that you may not have made that decision up front.
Right.
And just because they're telling you this, then they're actually going to take the medicine, or they're going to use the medication, and then they're going to actually have a different outcome. Their life, being able to go to work because your kid's not staying home sick.
Right. So what you're bringing up then is a couple of points. Is why would the patient want that? Well, actually, maybe we've got to make sure that the patient does want that they understand what's the good that's going to come of that. And one of the easy kind of selling points or hooks to that is by saying, you'll have a better outcome because you'll know what you're doing. So you'll be adherent with it. You'll stick with it. But don't think that you don't have a voice. You have a voice, and you actually have a preference. So, you know, I want you to think about in your house, who makes the menu for what's for dinner? So in your houses, who makes the menu of what's for dinner? You make the menu. Okay, anybody else? I make the menu. I'm the one that decides what's for dinner. You make the menu. Anybody else?
We swap and cook, so whoever's the cook is for the night.
Whoever the cook is. So in that case, whoever the cook is gets to make the decision. You don't know what a luxury you have when you're not the cook. That's the thing, which is what you're talking about, is that if I don't need to make the decision, then somebody else can. Now, as somebody who makes the decision all the time, I'm burdened. But if I never had a chance to make the decision and I'm really craving tacos, will I ever get them? And that must be very frustrating, is that if I never get the opportunity to make the decision about my health care, about what medications I go on, about how much money I spend on it, about if I take something 3 times a day or once a week, that must be very frustrating. And those are the kinds of things that we need to highlight. That there's got to be a balance between, I wish somebody else would decide what's for dinner, and I am always the one who has to come up with what's for dinner. So, all right, great real world examples. Now, the disproportionate impact of asthma is in racial and ethnic low-income populations. And we know that, and that's particularly why this whole summit is being had, is to be able to put the spotlight on that and what shared decision-making can do for that. But for people who are not attending this summit, if you had to kind of give your elevator speech and say, why is shared decision-making important, particularly in this low-income population? What is the example that, again, telling stories, what is the example that you could give? Give me an example of a patient that's in a racial minority or in a low-income group, and that they don't have shared decision-making. It's not part of their therapy. And what would be that real-world scenario? Go ahead.
I'll give you an example. So my mom, in Hispanic households, like works alone again. And my mom and I were just talking the other day of how, like, if you can't see what the ailment is, like if your bone is not physically broken,
Yes.
you have to cross that barrier of explaining with our family especially, okay, like this is what's happening. So if you can at least get that foot in the door of they acknowledge that something's happening, then they can also help to take control of, like, okay, I need to take this medication. If I'm self-aware that I don't like to take medication, maybe this is something else that I can do instead.
Right.
But that's always been a big thing in our household and family, is if they can't see it on outward presenting.
Yes.
It's hard for them to even believe something's happening.
Oh.
So that, I mean, like, I know that that's like another layer.
No, but those are great examples. Those are great examples. So what you're bringing up is, let's take the last one first, is family. If the family doesn't understand that it's happening because they can't see it, so you're not hemorrhaging on the floor. So when you're saying it's not easy to breathe, let's say for an asthmatic, it's not easy to breathe. They can't see that until what? You turn blue and you're passed out on the floor? And so the problem with that is there's a gap, and the gap in the care of that patient that is from a Colombian background is not understanding that I need to give that patient the tools so that their family can understand that we don't have to wait until mom's blue and on the floor. And what would something be helpful for the family to understand? And here is where we really do the art of medicine. I'll give you a simple example, is we talk about the rule of 2s with albuterol. You should not use your albuterol more than 2 puffs twice a week. That's 4 puffs a week, right? That means your asthma is in control. I mean, this is basic stuff. 2 puffs twice a week, 4 puffs a week. Times 52 weeks in the year is 208 puffs. 208 puffs and your asthma is in control in a year. Every canister has, it says on the label 200 puffs, but by law, there's got to be about 10% more in case you just kind of use it as an air freshener there for a bit. So you have a year's worth in a canister. If the family members see, Mom, you just sucked down one of these inhalers in a week or in a month. Okay, 15 minutes, really? I thought I have till 1:45.
1:30.
Oh,
But we were later,
okay,
so.
I'll do whatever it is. If the family sees you're using this so quickly, then the family needs to be able to say, hey, you just used a year's worth of medicine in a week, in a month. Those are very helpful examples. Okay. Improving literacy, I think we've just given that example. What does it look like? How do we do that? And we've just given an example of you first elicit what's going on in your life, and then you give them examples. All right. I'm going to skip over these in order to get to, because a lot of these are sort of repetitive. Empowering providers to elicit patient preferences and patients to contribute their preferences to the provider about their asthma care. What I want you to give me is, what are the qualities that make an empowered patient? So what does an empowered patient look like? They have knowledge. Okay. What else?
Choices.
Choices.
That they're compliant and follow what they should be doing and they know why.
And because they know why, right? Because they internalize why. What are the qualities that make them internalize the why? What are the qualities that make them want to get the knowledge? But what's the quality in them?
Curiosity.
So curiosity is a great one. They're curious. It helps them. They are self-advocating. They realize I need to help me. So they have qualities of being self-advocating. And they realize that I got to be curious about this. I can't be passive. Those are the qualities. Go ahead.
Sometimes too, just saying, do you want this to be different?
Yes,
Because they don't, when you grow up with the disease, that's all you know.
right.
If your lungs don't work, you just know you can't do certain things and you don't ever think about what would it be like if I could do whatever I want.
So when you ask somebody, do you want this to be different? You're asking them to be self-assessing. Those are the qualities. Because what we need to be able to recognize is, how does somebody do that? We can list what we want them to do. We want them to be adherent, but how? Because they're purposeful. That's the quality, right? That's the quality that comes from the patient. They are purposeful. Why are they purposeful? Because they're knowledgeable. But what made them want to gain the knowledge? Because they're curious. So it's very,
They need to own it, believe in what they're.
and they want to self-preservation, right? Survival instinct. And they want to put themselves first. And why do they want to put themselves first? Because they're a mother, because they're, yes.
I was gonna say, part of it too is also just feeling safe enough to ask the questions to lead to the.
Right, so they feel confident, right? And they feel confident because they feel safe. If we don't dig down to these kind of virtues, these kind of personality traits, we can talk all we want about you should, and we will should all over ourselves, right? You have to be able to get to the business of, what does that look like? And then bring that forth. It's very much like parenting, right? You have to be able to find those gems inside of the child and bring forth those virtues, those qualities. So that's why it's so important to think about, what does that patient look like? Then when it gets to, we want to be able to do things where we do teach and give knowledge, what does that look like? How do we provide that to patients? So what are some ways that we can provide this kind of education, knowledge to patients?
It sounds like a really, like it's not a novel idea, but because of how our healthcare system is designed, we can't time.
Yes, time, that's right, that's right.
Give a patient time.
Right.
The patient doesn't feel like, I can't ask any questions because the physician's only gonna be in here for like 3 minutes and then they have to go.
Right.
somewhere else and then-
So that's a very real thing. So tell me, how can we do this? Think about this. I'm not gonna give you any more time. I don't have any more time, right? My schedule is full. And the bottom line is if I give you all more time, I won't ever get out of here. And I already don't get out of here. So I'm not giving you any more time. All right, so what can we do? What are ways that it's not my time?
Having, whether with, you know, with the whole COVID experience and people getting pushed into this technology
Yes,
world.
Absolutely,
Having pre-recorded videos about, today we're gonna talk about.
right.
And you say, here's this whole series and I want you to watch 3 of these and then make another appointment.
That's right.
And watch 3 of these and
Yep.
make an appointment. And some of the things that we see are that you're getting people, and with the Florida Asthma Coalition, one of the things that we're trying to do is build the awareness at the pharmacy, at the primary care provider's office, you know, even with the specialists, at the school, at the daycares, with the hospital system. Like, there has to be a group of people that are here to talk to patients. And you may not be making a profit off of it. You may not be getting reimbursed for that, but it still has to be present, because that's where that time becomes an extension, so that the physician doesn't feel like they
Have to do it, right? But I'd like to give you this idea is we can't suddenly, I can't dip into somebody else's payroll, right? And I can't say to CVS and Walgreens, your pharmacist needs to be able to provide this. But I can certainly, and people like the Florida Asthma Coalition can certainly come up with pithy little quick things that would say, you know, here's a picture of a bunch of inhalers, a bunch of albuterol inhalers. I mean, I'm just coming up with this one on the top of my head. Bunch of albuterol inhalers on top of a gravesite. How'd you get here? Or you don't want to get here. And they see all these albuterol inhalers on top of the gravesite. Now I'm curious. Now I want to be educated. Now I want to put myself first and I don't want to die. And then I go learn, rule of twos? That's what that meant? And I go learn that from a video. I go learn that from somewhere else. I don't learn that from the pharmacist, who's not going to be able to make the impact of the Hollywood video that the Florida Asthma Coalition is going to make, right? Because the impact of the video that you all can make is literally, there's a bunch of empty inhalers on top of a gravesite. Or, you know, another great one is, I always laugh about the silhouette profile of an asthmatic who's about to die. And that is, it's a man who has a cell phone in his back pocket. That's always part of somebody's silhouette, but who has the bulge of an inhaler in his front pocket. Why is he walking around with an emergency medicine? They don't walk around with emergency defibrillators. People that have seizures don't walk around with emergency helmets, right? Nobody does that. Why are we letting people walk around with emergency inhalers? By definition, they are going to overuse their albuterol, and that is going to lead to them dying. And why? Because they're not taking their maintenance medicine. Why aren't they taking their maintenance medicine? Because nobody made it that simple. Use this albuterol inhaler more than 1 a year and you will die, or you have an increased risk of dying, right? So those are ways that don't have anything to do with time. Another great one are a whole bunch of, on this slide, we're talking about what kind of elements do you need? And one of them could be like checklists. Checklists or questionnaires are a great one. Having people just go through the ACT questionnaire. Having them just realize, how many times do I wake up at night? What is my score? And to recognize that I don't want to have this poor score. That's not what I'm after. The worse my score is on the ACT exam, the greater the chances I'm going to miss my grandchild's kindergarten graduation, because I'm going to be in the ER. And I really want to make it to, I finally got tickets to the Lion King, and I really want to make it to that. It's Mother's Day, it's Father's Day. I want to be able to participate in the barbecue that we're making for Dad. But if your ACT score is poor, you're not going to be participating in that. So questionnaires are another great tool. We talked about this just a little bit, but there's two sides of the story, right? There's not just the patients, but there's also the provider. So in terms of the provider, how can we help them understand this patient journey? And I think an awful lot of it is to tell those stories, to make that very real, to be able to say, here's a story of a patient who came in and walked out with all these prescriptions that she was like, what? We didn't talk about that. For somebody to be able to realize, do I do that? And to be able to have coalitions like the Florida Asthma Coalition come up with these shared decision-making tools that are already provided. Have your patients watch these videos. We've got QR codes all over the pharmacy that as they're waiting in the long, long line in the pharmacy, they can pick up and look on their QR codes to watch these videos. That we've already got these things provided. You don't need to do that. Lastly, how does this actually pay off? I mean, there really are statistics for this, so I will quickly bring you through these.
You are fine, just so you know.
Okay.
I'm enjoying this.
Okay.
You're okay.
We're good. Okay.
Because we have to start right after.
Okay.
So we can,
So we can.
you're good.
Okay.
Thank you,
All
sorry.
right. No, thank you for telling me that. Yeah. Okay, so this isn't just a bunch of hoi polloi, right? This isn't just a bunch of like, wouldn't it be nice? This is the way a doctor should be. This is the way the doctor-patient relationship should be. There really are statistics behind it. And this is really where the rubber meets the road, right? Or this is really the money shot, is 71% of patients are satisfied when they go through shared decision-making compared to 35% that are unengaged, right? So if you have a much higher satisfaction rate, I mean, first of all, for me as a clinician, the reason that I suffered through medical school, and then the reason that I get up every day is to help people. I don't want to only have 35% of the people helped, and I missed the boat with 65% of them. You know, I don't want to cook Thanksgiving dinner and have only a third of the people say that was tasty. Otherwise, why am I hosting? I mean, I really should take them all out to a restaurant, right? So I don't want to have such a high dissatisfaction rate. I want people to be satisfied. And then if they are satisfied, what we know is they're engaged, they're adherent, they have a better quality of life, they have better outcomes. But this is, you know, real data from shared decision-making exercises is that 71% of the patients are satisfied. And that after 6 months after a shared decision-making activity, their quality of life is higher. Which again is why we do what we do, is I get up to help people. I want to make their lives better. Lastly, patients who made informed decisions were less likely to regret their treatment choices. So 5% compared to 15%. So let me tell you an easy one for that is something that many asthmatic patients are on, is they may be on allergy shots or they may be on a biologic. There is a lot of work I have to do as a provider to get somebody on allergy shots or on a biologic. And for those of you who have been on biologics or family members of biologics, you know all about the prior authorizations. If I say, so you want to do a biologic? And you're like, yeah. And then I go off and I have my staff work to get you this biologic. And then you have buyer's remorse and you're like, I don't know if I want to do that. A bio what? Stick a needle in where? How often am I doing this? Has anybody ever done this before? But I want to have a baby. Can I do that? All the questions that naturally are going to come into your head. If we went through something shared decision-making, you'd be able to ask all those questions. Again, maybe not directly of me. You may even be able to get through this shared decision-making questions with a chat bot. You may not literally need a person. There are ways that we can program all this so it really can happen and it doesn't take up any of my time, but it gives you curious, motivated, self-aware, self-preserving patient the tool to get through this. And then when I finally go through begging to get you this prior authorization and it comes through, you pick up the phone when the pharmacy calls and says, are you ready to have this delivered? Because this happens every day in doctors' offices. We talk about doing a biologic and then you change your mind. And then you don't pick up the phone. And there's medicine waiting for you and you don't pick up the phone. And then you're embarrassed and you skulk away. And then we never connect again because you're embarrassed that you put me through this. So that's an easy real world example. So again, these are studies that literally show that if you make your own healthcare decision, you have better health outcomes for all the reasons that we talked about. You have decreased anxiety because if you're like, I feel like I'm just being herded along into this. I feel like this doctor is, for whatever reason, shot happy, right? This happens all the time with allergy shots. I feel like the doctor just cares about making shots. They're just a shot shop. They just want to, get me on shots. They just want to, and this can happen in any specialty. They just want to cut off my knee and put in a new one. They just want to upsell me hyaluronic acid. They just want to, whatever it is. But this decreases that anxiety. Did I make the right decision? Should I have researched this a little more? Wait a minute, let me put the brakes on this. You'll have a much quicker recovery because we know what you're supposed to be doing. So instead of saying, well, I'm going to start this therapy, but then I'm going to hold back for a while, you're not going to get as quick as fast. So what happens with that use of decision aids? You end up getting reduced number of passive patient treatments, as we just said, increased adherence to knowledge, accurate perception of risk, and reduced conflict. Here's a couple more quick studies, just that it is cost effective when you actually have the ability to have patients decide, do you want this less invasive choice, or this is a surgery sort of a thing, then informed individuals make a cost effective and less invasive choice when they have a preference, when they're given an opportunity. That it doesn't necessarily increase cost. Patients don't always say, oh, if I can get the $1 million treatment, give me that. They don't often say that. There was one particular study on menorrhagia, which is bleeding from menstruation, and how to treat that, and that they actually saved money, right? People who had the ability to weigh in on their choices. Hip and knee replacements, that also led to 38 fewer surgeries. So people weren't like, hey, if my insurance covers it, sure, sign me up for that. Resulted in patients having 20% of patients opting for, again, that less invasive surgery. So here is the take-home slide. Shared decision-making is a process in which clinicians and patients work together to make treatment decisions in a way that balances clinical evidence on risks and expected outcomes with patient preferences and values. Researchers find enormous gaps between what patients want and what doctors think they want. And again, I think that's an important thing, to just go into every doctor and say, you're wrong. You think this, and I don't know if you think this because you think it's your role or you think you've been appointed by God. I'm not quite sure, but it is not what the patient wants. Shared decision-making can address this communication gap, improve outcomes, and increase patient and physician satisfaction. It's a key component of person-centered healthcare and should become the standard of care. And then these are the illustrations from the papers that we used. Yes.
I have a question. Do you feel like in practice, when you have a patient that's really engaged in shared decision-making and, because one treatment, usually you do have to sometimes try several and fail, and then you find something that works. Do you feel like they are more receptive to the failed therapy if they have the opportunity to say, we're going to try this, you let me know if this doesn't work, then we'll try something else?
Yes.
This isn't working for me.
Right.
Like they come in angry when
Right.
the treatment isn't working.
As if that's my fault.
Right.
Right.
And you're like, there's 1,000 things that go on to here, including how to use it.
That's right.
Genetics, your biology,
Right.
everything else. but sometimes this isn't the right fit. You know,
Right.
It's like shoes and clothes. Everybody's willing to try on before you get the right outfit, but they think it's a one-shot. event.
Right. And so what you're bringing up is, so one part of my background is that I'm a Baha'i. That's my religion, and the Baha'i faith believes in unity. And there is a particular tool that we use called consultation. And the important part of consultation is that everybody gets to give their ideas when making a decision, and that when you put in your ideas, it's no longer yours. And then the group really decides what is the best course of action. And because you decide that course of action in unity, when it turns out that, whoops, we went the wrong way, we made the wrong decision, it is much easier to fix and go the other way, because it's not like, see, that was your lousy idea. We followed your lousy idea. And then you're going to fight tooth and nail to keep going in this direction. And you won't really assess and go, this idea didn't work. But the group as a whole can say, which the group may just be physician and patient, can say, we in unity decided to make this next step. And it didn't work because you had a side effect, because we couldn't get it, because it just didn't work. The therapy didn't work on you. For whatever reason, it didn't work. Let's not just keep hanging in there doggedly thinking that something's going to change in the next month. Let's make that decision, change course, and go in another direction. And the direction we go to is in unity. It wasn't my bad decision. It was our decision trying to figure out which way to go. Yeah, and that leads to, again, really what one of those statistics was, you get a much quicker improvement in your health because you're not hanging on to an old idea. When both parties agreed, that didn't work.
And I think just some of the experiences is, I've worked in several different pharmacy settings, and sometimes you hear patients like say, well, you know, I don't know why my doctor gave me that. And so like, I was always compelled to be like, well, here's the deal.
Right.
Like, let me tell you that you have a great doctor, because that's my doctor too.
Right.
But it's not your doctor. This is a system issue.
Right.
We wanted this drug for you because we knew it was going to be best, but the insurance blocked it.
Right.
And so we're going to go with this one instead. And then this one doesn't work, then we get a chance to go back to the other one.
Right.
So like having to referee that out.
Yes.
You know, and not knowing if you guys still see some of that too, but like patients that get to be a part of it, it's sort of like if you know you're a part of it, then you don't get to like dump on the you know, that party. And it I think for me, and what I've seen is it increases trust in that the physician is going to make this journey with you for the best outcome. And along the way, there's going to be bumps, but you're not going to be alone in them. And
Right.
you're going to still have a team there to help you overcome stuff.
Right. Right. I mean, that's my job is to accompany, right? My job is not to be the tip of the spear. My job is to accompany. And if it comes into one of those that the insurance company says no, and it's not a Coke versus a Pepsi, right? If it's a Coke versus an orange juice, I mean, they're beverages, but woof, they are very different, right? Is that if I have the patient understanding that the insurance company is pushing Pepsi above orange juice, they will go to bat and they will be able to get this done if it can be done. And if it can't be done, then we need to be able to regroup and figure out what can be done. Right, but that's because we're working together on this and accompany this, and it's not my job solely to both make the decision about, are you going to be okay with this? And make the decision of, and I need to get you this. It's the only thing that we'll do. Right. So I think we're way over time, but shall we break?
Yes, we'll actually all be going back to the auditorium for a poster presentation. There will be a speaker who will be providing that presentation. So if everyone's ready.
Okay. Well, thank you for your participation.
Thank you.
Very, very appreciated. Thank you.
Appreciation.
Okay, thank you for that.
Thank you so much.
Thank you. Yes.